The muscles of the forearm and hand are designed for precise control of wrist and hand movements. They don't easily handle the repetitive motion activities that come with modern living, and consequently, many overuse injuries of the forearm and hand result. The tennis elbow test is used to assess overuse tendon disorders affecting the common extensor tendons at the lateral epicondyle of the humerus. It's really just a modified manual resistive test with pressure added in a specific location. The wrist extensor muscles share a common attachment at the lateral epicondyle of the humerus. The wrist flexor muscles share a common attachment at the medial epicondyle of the humerus. Both sites are common locations for overuse tendinosis complaints, and our first two tests are used to evaluate these problems. Keep in mind with the extensor tendons that are involved with lateral epicondylitis, their attachment is here at the lateral epicondyle, but the tendons are just distal to it. So in this test, place your thumb just distal to that epicondyle so it can press directly on the common extensor tendons. This is also going to be a manual resistive test that's going to focus on the motion at the wrist. So when you're resisting that motion, make sure that you're not having elbow, it's actually wrist motion that you're going to resist, not motion of the elbow this way. So we can resist that motion of the wrist and isolate those extensor tendons. So what I'm going to do is to simply have Bailey hold that position. Again, hold it there with your wrist, and then I'm going to press in with my thumb directly on those extensor tendons and see if it reproduces the pain that she's been experiencing. So it's a manual resistive test with wrist extension and thumb pressure directly on the common extensor tendons. Similar to the tennis elbow test, the golfer's elbow test is used to evaluate for overuse tendon disorders of the forearm, such as medial epicondylitis. In this test, the emphasis is on the common flexor tendon attachments at the medial epicondyle. Similar to the previous test when we looked at this for the common extensor group, here the flexor group is going to attach at the medial epicondyle of the humerus up at that bony prominence. The tendons are going to be just distal to that point. You might usually do this with the opposite hand coming in here and holding the tendons this way, but I'll use this hand so that it keeps the flexor group visible. I'll place my thumb directly on the tendon, and then down here at the wrist, I'm going to offer resistance this time to wrist flexion. So I'm going to have the client hold this position here, but I want to make sure that I'm engaging only wrist flexion and not any elbow movement. The fewer muscles that are recruited, the better. So make sure that your hand is resisting across the resistance is across the hand and not causing any elbow movement. So I'll have Bailey hold this position here, don't let me move it, and then this thumb is going to press in on those common flexor tendon attachments right there. Good. If there is pain or discomfort felt in this region, this could be indicative of medial epicondylitis or some type of overuse tendon disorder affecting the common flexor tendon attachments. The elbow flexion test is used to assess adverse compression of the ulnar nerve, especially near the cubital tunnel of the elbow. On the posterior side of the elbow, the ulnar nerve courses through a small tunnel created by the two heads of the flexor carpi ulnaris muscle. Nerve compression that occurs in this location is called cubital tunnel syndrome, and the elbow flexion test is commonly used to investigate for nerve compression in this region. In this procedure, I'm simply going to have the client adopt a position where her elbows are flexed and wrists hyperextended, and she's going to hold this position for about 45 to 60 seconds. What's going to happen is if that ulnar nerve is being compressed in the cubital tunnel, notice it's also being stretched here across the wrist in this position. By holding this position, she may have neurological symptoms that come on. If they appear within about 20 to 30 seconds, this is usually indicative of some type of compression occurring here in the cubital tunnel or along the pathway of the ulnar nerve. So keeping the ulnar nerve stretched but compressed across this area may reproduce those symptoms. This would be indicative of ulnar nerve pathology, most likely, as we said, here in the cubital tunnel. The median nerve can become entrapped by the pronator teres muscle. The symptoms of median nerve entrapment can be virtually identical to those of carpal tunnel syndrome. The pronator teres test is helpful in distinguishing between these conditions. The pronator teres muscle is easily palpable on the anterior aspect of the elbow. It has two separate heads, and the median nerve courses between these heads, making it susceptible to compression in this region. Taking a look here at the forearm, remember that the pronator teres' primary action is to pronate the forearm, or turning it over this way. So what I'm going to have Bailey do is to engage that contraction of the pronator teres. We're starting with the elbow in a flexed position so that the pronator teres is slightly shortened here. So now, Bailey, I want you to hold this here and don't let me move it. I'm trying to turn her wrist into supination, but she's trying to fully pronate her wrist, turning it over that way. So keep that wrist tension on, hold that wrist position, and I'm going to straighten the elbow out as we do that. By bringing the elbow into an extended position, we pull and elongate that pronator teres while maintaining a contraction on it. Let's look at that one more time. Again, hold that wrist in this position here stiff, and then I'm going to take my hand just around the back side of the elbow simply to help straighten the elbow out while she maintains the wrist motion. If, in producing those sensations, there is pain or discomfort felt in the median nerve distribution in the wrist or the hand, this could be indicative of the pronator teres causing median nerve entrapment. A branch of the median nerve called the anterior interosseous nerve can sometimes be compressed by the pronator teres muscle. It's primarily a motor nerve for the index finger and thumb, and it's evaluated with the pinch grip test. In this procedure, have the client pinch the finger and thumb together as strongly as possible. You should be able to see a nice curvature of the top of the finger across here. If there's damage to the anterior interosseous nerve or compression of that nerve, when she attempts to pinch her fingers together like that, she won't be able to hold this position, and the distal interphalangeal joint will collapse into hyperextension like this. That would be indicative of compression of the anterior interosseous nerve. The Phalen's test is one of the most frequently used special orthopedic tests for evaluating median nerve compression in the carpal tunnel. The carpal tunnel is located at the base of the hand. There are 9 hand and finger tendons surrounded by a synovial sheath. Along with the median nerve, these tissues course through the carpal tunnel. The tunnel is covered by the flexor retinaculum. Carpal tunnel syndrome is caused by compression of the median nerve within this tunnel. Begin by having your client adopt a position with the hands folded in full flexion, so the wrists in full flexion, and simply hold this position for about a minute. If symptoms are felt in the median nerve distribution of the hand within about 20 or 30 seconds, this is considered a positive test indicating potential compression in the carpal tunnel, the median nerve being compressed in this region. Sometimes this is also done with a separate variation called the reverse Phalen's test, which simply has the hands in hyperextension instead of in flexion at the wrist. In this instance, the median nerve is being stretched across the carpal tunnel instead of being compressed. In either event, if symptoms are felt within about 20 or 30 seconds of holding that position, this would be indicative of potential median nerve compression in the region. The tethered median nerve stress test is a recently developed orthopedic test for evaluating adverse median nerve compression. It's not considered accurate when used alone, but can be a valuable part of the clinical evaluation when combined with other assessment procedures. For this test, bring the client's arm up into a position so that there is elbow extension and the median nerve can be in somewhat of a stretched position. The wrist is going to be extended fully, and just take the client's index finger or their middle finger and pull it into full hyperextension and hold this position. If symptoms are felt in the median nerve distribution of the hand, once you put stress on and pull that nerve structure, that could be indicative of adverse compression across here at the carpal tunnel or along the distal length of the median nerve by pulling and tethering that median nerve at the same time that we're stretching it across all the other regions there. If there's symptoms, again, reproduced in this area, once we apply that pressure and pull stretch on the nerve, this could be indicative of potential median nerve compression pathologies affecting the median nerve in the carpal tunnel or the distal region of the hand. The ulnar nerve can be exposed to compression on the anterior surface of the wrist. The Froment sign can be used to evaluate for nerve compression in this region, which characteristically affects one of the primary motor branches of the ulnar nerve. The flexure retinaculum spans across the base of the hand and creates the roof of the carpal tunnel. The ulnar nerve is in this region as well, and a small slip of connective tissue spans from the retinaculum across the ulnar nerve, creating a separate tunnel for the ulnar nerve to pass through. Compression of the ulnar nerve in this region routinely affects the adductor pollicis muscle of the thumb and causes weakness and atrophy. The motor branch that we're concerned about here is one that comes in and innervates the adductor pollicis muscle, which is this thick muscle on the fleshy part of the thumb right here. For this procedure, we're going to see if Bailey can hold her wrist in this position and hold the thumb firmly against her hand here by trying to hold a piece of paper and pinch it between the thumb and the hand. Take this paper and fold it over several times so that it's got a little bit of thickness and doesn't tear too easily. I'll slip it in between her thumb and palm, and I'll tell her to hold this position, and I'm going to try to pull that paper out of there, and I'll tug it, and she can firmly hold on to this because that muscle has got a nice good degree of strength to it. If the muscle is damaged, when I tell her to hold this position, I can easily slip that paper out, and I tell her to just hold it as strong as you can, and I can still pull that paper out of there easily. If this is an instance where she's unable to hold the paper, this could be indicative of ulnar nerve compression in the Guillon's tunnel affecting that primary motor branch of the ulnar nerve. The Finklestein test is used to identify adhesions between the tendons and their surrounding synovial sheath on the radial aspect of the wrist, a condition known as de Quervain's tenosynovitis. There are two tendons on the medial side of the wrist surrounded by a synovial sheath. The tendons are from the abductor pollicis longus and extensor pollicis brevis muscles. This region is sometimes referred to as the anatomical snuff box. The tendons and the surrounding sheath are covered by the extensor retinaculum. Pressure of the tendons against the retinaculum can cause adhesions between the tendon and the sheath. For this procedure, have the client take their thumb and place it across the palm, and then she'll wrap the fingertips across the top side of the thumb and then move the wrist into ulnar deviation. That motion is going to stretch the tendons right here across the radial side of the wrist, the tendons that are primarily being stretched into de Quervain's tenosynovitis. This can be done actively as she's done it, or it could also be done passively if I pull and stretch the tendons in that position. In either event, we're looking to see if it reproduces pain on this side of the wrist by holding in that position. The pain in this region would be indicative of potential tenosynovitis or irritation of those tendons and their surrounding synovial sheath. The upper limb neurodynamic test number 1 is designed to assess for adverse tension or compression on the median nerve. It's a useful evaluation tool for examining dysfunction of the median nerve anywhere along its path. Reviewing the path of the median nerve is helpful for understanding the upper limb neurodynamic tests. After leaving the cervical region and coursing under the clavicle, the median nerve passes under the pectoralis minor muscle, runs along the medial arm, and then across the anterior face of the elbow. It then follows straight through the middle of the forearm and into the hand. Begin with the client's arm fully at their side, and with this procedure, we're going to successively add tension to the median nerve all along its length. If at any point during this process the client feels a reproduction of neurological symptoms, then we halt at that point. Begin by bringing the client's arm up into this position here with the elbow flexed. We'll bring the wrist into extension and supination. From here, bring the client's arm up into abduction, then lateral rotation. At this point, you may want to slide forward so that you can sort of hold the client's arm in this position with your thigh if necessary, and then bring the client's arm fully into elbow extension. And the very last step will be the client laterally flexing the head to the opposite side. So Bailey, you can laterally flex your head to the opposite side. Good. Any symptoms felt there?
A little bit in my shoulder.
A little bit in the shoulder, okay? And come back to the neutral position. What you're mainly looking for is any symptoms of neurological sensation down the upper extremity into the hand along the pathway of the median nerve. Any of those symptoms that are reproduced at any point along that test could be indicative of median nerve pathology somewhere along its length. The upper limb neurodynamic test number 2 also evaluates for neural pathology of the median nerve. It's not as accurate as the first test, but can be used in situations where the first test cannot be used, such as a person who might have shoulder instability where you wouldn't want to abduct and laterally rotate the shoulder. To begin this procedure, the client is positioned somewhat diagonal on the table and her shoulder is off the edge of the table. I'm going to place my thigh against the upper edge of her shoulder and push it and hold it into depression. So I'll lean in, hold her shoulder in depression, and then I'm going to take her arm down, and we'll begin here with the elbow in a slightly flexed position. And then we're going to extend the elbow. We're going to extend and supinate the wrist, turning it so that her fingers will end up pointing towards her body in a medial direction. And then the last step will be her laterally flexing her head. If you will, Bailey, I want you to laterally flex the head to the opposite side. And that's the final degree of stretch on those median nerve tissues from the brachial plexus. Okay, come back to the neutral position. Again, if at any position along the length of those procedures, symptoms are reproduced in the median nerve distribution, this could be indicative of median nerve pathology. The upper limb neurodynamic test number 3 evaluates for potential neural pathology affecting the radial nerve. There are not a large number of radial nerve pathologies, but this procedure is valuable for ruling out the possibility. After leaving the cervical region and coursing under the clavicle, the radial nerve passes under the pectoralis minor muscle and along the back side of the arm. It wraps around the posterior side of the humerus and crosses the elbow near the lateral epicondyle of the humerus. It then courses down the posterior side of the forearm and into the back of the hand. As with the number 2 procedure, you're going to begin with your client diagonal on the table and her shoulder off the edge so that you can hold it into depression with the thigh, just like we did before. Begin with the elbow slightly flexed, and then we're going to extend the elbow, this time flexing the wrist and pronating the forearm, turning it as far into that stretch position as possible. And the last stage will again be the client laterally flexing the cervical region to the opposite side. So Bailey, go ahead with your head and neck into that lateral flexion position. Very good. That stretches the upper brachial plexus. Then come back to neutral. Again, with the neural tension testing procedures, what you want to do is to stop and pause after each additional step and see if it increases the symptoms at all. If it does, you don't need to keep going through the symptoms further. This could be indicative, in this case, of pathology affecting the radial nerve anywhere along its length. The upper limb neurodynamic test number 4 assesses for neural pathology of the ulnar nerve. The positions in the neurodynamic test can be used for both assessment and neural mobilization treatment, so these are valuable procedures to learn. After leaving the cervical region and coursing under the clavicle, the ulnar nerve passes under the pectoralis minor muscle and along the back side of the arm. It crosses the elbow on the posterior side and then follows along the medial forearm into the hand. It crosses the anterior side of the wrist and terminates in the palm. Again, begin with the client's arm at the side. In this procedure, we're going to begin with the elbow in an extended position. The wrist will again become hyperextended and supinated. Bring the client's arm up into a position of elbow flexion. At this point, it may be handy to turn the hands around so that this hand is on the wrist and hand, the other hand is supporting the elbow down here. I'm going to bring the client's arm all the way up into full abduction, and notice the fingertips will end up pointing down. And the last step, again, I'll have my client laterally flex the cervical region to the opposite side. So Bailey, if you will, go ahead and laterally flex to the opposite side. Good. And come back to our neutral position. If at any point along that way any of the symptoms are reproduced, this could be indicative of ulnar nerve pathology. So again, at any point along there where symptoms are felt, pause and stop at that point. You don't need to keep going through successive places because that may be indicative of neural pathology in the ulnar nerve.